In an interview with Stephen Fry, the late Carrie Fisher spoke about her own experiences with bipolar. When you're galloping along at a great speed, it is better than any drug you could ever take. God, if you will, is saving you parking spots. Songs are being played on the radio for you. I've got this great idea. I've got this unbelievable idea. Let's go to India. And even if it's not true that you're more talented when you're manic, you feel like you are. She recalled, "I stayed awake for 6 days and I did lose my mind. This friend of mine says to me, 'Does your doctor know that you behave this way?' 'What do you mean?' Then we sort of have this argument and I cry for 4 hours and I am unable to stop, and I know there's something wrong with that." Throughout this course, we've been looking at the biopsychosocial approach to mental illness. We'll continue this theme as we discuss treatment for bipolar disorders and look more closely at how these treatments differ as the person with bipolar moves through the different stages of the disorder. We spoke in the last video about the different stages that a person with bipolar goes through, from asymptomatic but with a family history, all the way to constant, unrelenting manic or depressive episodes. Just like other medical conditions that go through stages like cancer, for example, treatment is most effective when the approach is tailored towards the particular stage that the individual is currently in. The most well-known and effective treatment for bipolar disorder is a biological intervention, the mood-stabilizing medication lithium. Lithium has up to an 80% success rate, especially when the condition is diagnosed early. Some of the best outcomes are also achieved when it is used in combination with psychosocial interventions that help the person with interpersonal and practical problems like managing their finances. Patients who don't respond to lithium usually have bipolar with psychotic features, and so they're often prescribed an antipsychotic medication or anticonvulsants. As with all mood disorders, relapse and recurrent episodes are common, particularly in the long term. And so treatment efforts must focus on the maintenance aspect of the disorder, that is, on preventing relapse and reoccurrence. So what do the treatment interventions look like at each stage? Stage 0 describes people who have risk factors, such as a family history of bipolar, but they haven't started showing any obvious symptoms. Aside from genetics, some of the other risk factors include problems during childbirth, physical, psychological, and sexual abuse during childhood, and substance abuse. Because these risk factors are not exactly rare, and we can't treat every person who has these risk factors as if they're going to develop bipolar, we know that most people will not. Instead, some generic interventions that can be helpful for all of these people can be encouraging self-help strategies, counselling, encouraging safe use of substances, and educating these people so that they are aware of the early signs and symptoms that they should look out for. Stage 1 is what's known as the prodromal stage. People in stage 1 begin showing mild, non-specific, but still identifiable symptoms of psychological distress, and this usually begins in adolescence. Once again, because the symptoms are so broad at this stage, and there is still a very good chance that people showing these symptoms do not, in fact, have bipolar, the interventions too continue to be broad and usually include CBT and family counselling. Stage 2 is where some researchers begin to disagree. People with bipolar usually experience depressive episodes first, but the DSM and the ICD criteria specify that at least one manic or hypomanic episode is required for a bipolar diagnosis. So it's a bit of a catch-22. And this is reflected in the different stage interpretations that have been described by different researchers. Some will call the first depressive episode stage 2A, whereas others say that the person has reached stage 2 only during their first manic or hypomanic episode. These minor differences are not important for our purposes. I just wanted to make you aware of them. One thing that all researchers can agree on is that a person with bipolar stands the best chance of living a healthy, independent life if they begin appropriate targeted treatment following their first depressive episode, or at least after their first manic or hypomanic episode. One reassuring aspect of mania is that these early episodes don't appear to cause significant or enduring structural changes to the brain. In Lecture 1, we spoke about the differences that clinicians face when they're trying to diagnose bipolar. Remember, if the person experiences a depressive episode first, all too often they can be misdiagnosed as having unipolar depression. If this happens, then the person may get prescribed antidepressant medication. The reason this is so bad is because in people with bipolar, antidepressants can trigger mania or rapid cycling between depression and mania. But this misdiagnosis may soon become a thing of the past. Some recent research has found that bipolar depression actually has some characteristic features, including biological differences in a chemical called brain-derived neurotrophic factor, or BNDF. BNDF is a neurochemical that helps support the growth and health of nerve cells. What researchers have found is that the BNDF levels are different in people with unipolar depression versus people with bipolar depression. This is still very early research, but if progress can be made in this area, it may be a useful diagnostic tool to aid early detection. This in turn would allow clinicians to begin treatment with lithium as soon as the person becomes symptomatic. Most often, stage 2 treatment consists of the mood-stabilizing drug lithium and CBT. Stage 3 is where the episodes of depression and either mania or hypomania keep recurring, but the person is still experiencing periods of complete remission in between. Again, intervention in stage 3 consists of lithium and talking therapies like CBT, but quite often the person will also require treatment for other comorbid conditions. Substance use in particular is common in untreated bipolar. As we mentioned in the last lecture, this is the stage where the episodes may start to develop spontaneously when previously they had always been triggered by life stresses. At the end of stage 3 and the beginning of stage 4, the person has usually had about 4 manic episodes or roughly a dozen depressive and manic episodes combined. This stage, the person tends to move from the recurrent stage 3 to the resistant stage 4. In stage 4, the illness can become unrelenting. The person is almost always in a state of either depression or mania, and they can show residual symptoms if these episodes subside. At this late stage, treatment options are limited. They must be aggressive and targeted to have any hope of the person maintaining any form of independence. ECT intervention can be recommended at this stage because, despite its inherent risks, the alternative may be worse. The overriding message being conveyed by all bipolar researchers is that it's best if the disorder is diagnosed and treated early. With early diagnosis and intervention, treatment is not only more effective in preventing or, at minimum, delaying the disorder's progression, the treatments themselves are simpler. If detected in stage 1, CBT and family counselling may be sufficient to halt progression. If the disorder is detected in the first depressive or manic episode, then they can begin mood-stabilising drugs like lithium, which have a really great success rate. But if lithium is not started until stage 3, then the rates of success begin to fall. Once the person is in stage 4, treatment options really are limited. Regardless of the stage a person is diagnosed in, the goals are always to reduce recurrence and to support the person to live an independent and fulfilling life. Thanks for watching. In this video, we looked in detail at the stages of bipolar and the types of treatments that are commonly used at each of these stages. I'll see you back here next week when we take a look at anxiety disorders.